Well, now that everybody is looking at their cover for the Broncos logo, I have the privilege of launching the first session of the symposium. And this is actually the first year that I've had a chance to be at the symposium, so it's a great privilege to have the responsibility to introduce the speakers for this very first session. And our very first speaker is Senator Irene Aguilar. She is a state senator from Colorado representing the Denver area, and a pretty amazing woman that I just met last night, actually. She is the Assistant Majority Leader and the head of the Health and Human Services Committee. She has been a champion of health care provision to the less able, and has been really instrumental in providing greater health care for those who are uninsured. You know, she is a mother of children, one of whom has disabilities. She is a woman of color. She's a leader in the Colorado Senate. She is a primary care physician, and so you can tell that she's actually a woman to be reckoned with. And so with that, I'm really privileged to introduce our first speaker, Senator Aguilar.
Thank you so much. All right, he handed me this like I would know what to do with it. There we go. So I want to get a sense of the audience. I was impressed with the diversity of people who I met last night and the different parts of the country and the world they were from. And so in order to get you engaged in your own healthcare, let me start by asking if you live and are registered to vote in Colorado, could you stand up? So I didn't let you get away with just your hand up. You had to stand up. Great. All right. Have a seat. If you understand how your health insurance policy works, could you stand up? Oh, very good, very good. So I start with that question because I am embarrassed to say that having graduated medical school in 1985, I first learned how health insurance worked in 2007, which is really embarrassing because I actually always worked for the county hospital, Denver Health and Hospitals, practicing primary care internal medicine. And I chose that workplace because I wanted to care for people regardless of their ability to pay, but I had student loans. So I wanted to be paid every 2 weeks. And so the beauty was that I sat in this back office and some people did some magic stuff, and then people showed up to see me, and I didn't have to worry about whether they could pay for things or not because we had a pharmacy, we had a hospital, we had specialists. And so I lived in this very sheltered, naive world. And in 2007, I learned reality. And so what I'm going to do now is talk to you a little bit about what I've learned from 2007, how that's influenced my work, and what will be on the ballot for those of you who live in Colorado in November of 2016. And so that is ColoradoCare and Amendment 69. I fluctuate between calling the Affordable Care Act, and Obamacare. I actually don't have an objection to the idea of Obamacaring, but I know it's used derogatorily, so I don't want you to think I'm using it derogatorily if you hear me say Obamacare. One thing people don't realize is, so I was one of those people who got really activated in politics in 2008 when President Obama was running, and was very excited about all his progressive ideas. And when he worked on healthcare reform in 2010, I stood back and said, that's it? That's all you can do? And then I got elected to the Senate and spent 1 month in the General Assembly, and I said, oh my God, how did you do that? So it's been a very eye-opening experience for me being involved in politics. And the words politics and science don't belong in the same sentence. Anyway, one of the provisions under the Affordable Care Act, and I just want to tell you about this up front because it's relevant to this discussion, is that in 2017, a state can apply for a waiver from the Affordable Care Act. And what the state needs to do is show to the Secretary of Health and Human Services that they are going to cover the same number of people with health insurance, that they are going to provide a similar level of benefit as under the Affordable Care Act, that it's going to be just as affordable for the people in that state, and that it's going to be financially sound and not increase the federal deficit over the next 10 years. So the next time somebody says to you, I hate Obamacare, you need to say, okay, what do you want to do in your state? Because starting in 2017, you can do that. And so that's what ColoradoCare is built upon. So what have I learned about healthcare and healthcare financing? What I learned is that in the early 1900s, when we discovered antisepsis and the ability to do surgery safely in hospitals, the cost of medicine began to rise. Before that, we all had this vision of the country doctor. Somebody just paid them out of pocket or gave them a chicken or an apple pie, and that took care of their medical costs. With the advancement of science and biosepsis, hospitals came into being. What was interesting was that they were a great resource, they provided great outcomes, but many people could not afford to use them. And so an administrator at a hospital at Baylor came up with this idea of offering the teachers in the Dallas-Fort Worth area access to the hospital anytime they got sick if they made a monthly contribution. And then they would get that guaranteed access. And that's sort of how insurance began in the United States. People would pay a small monthly fee on the off chance that they got something bad enough that they needed to go into a hospital and have something done. What's interesting is that in Europe, because they have a very different social contract with their population, when these advancements started, they started creating state country-based universal health care systems. And in fact, when Franklin Roosevelt was president and he was looking at trying to create something in the United States, the American Medical Association pushed strongly against it, not wanting us to have socialized medicine in the US, not wanting government to be involved in healthcare. And if you work in healthcare, you know how badly that failed. But anyway, so that was sort of the start of insurance, and other companies started up and realized that the easiest way to sell a policy was to a group of employees working for certain employers. And when World War II happened and there was a labor shortage, there were freezes put on wages, but employers were allowed to offer benefits to their employees. And that was how the association between employment and health insurance began. They couldn't pay the employee more, but they could offer to buy this insurance for them. So you had a bunch of people who were working, pooling their money into insurance policies, and there was an extra pile of money seen there. And the idea came up to, hey, why don't we make this a for-profit business? And so health insurance in the 40s and 50s became for-profit. The other thing that happened in the late 40s, early 50s was that Congress made employer contributions to health insurance tax deductible. And so the employer could buy insurance for their employee at a much lower cost than the employee could purchase for themselves. And interestingly, over time, the value of this benefit is up to, in 2013, $150 billion. So there, in 2013, were $150 billion of taxes that we did not collect because employers were providing health insurance to their employees. And that pretty much sealed the deal between employment and health insurance, and that was the way most people got health insurance in the past. What happened, though, was those of you in science continued to make advances, and the cost of medicine continued to increase, so that soon the policies cost more than many people could afford. And in addition, the people who were running these insurance companies as for-profit businesses realized that the best way to make a profit was to insure somebody who was healthy and not someone who was sick. And so in the 1960s, the government intervened in healthcare for the first time with the creation of Medicaid and Medicare. Medicare is a federal program. You look at your paycheck, you've been paying into it since the first time you paid payroll. And Medicare was to cover the elderly people because the insurers quickly realized that people over the age of 65 were likely to get sick and need medical care, and there was no money to be made there. You could not insure enough people to cover their medical needs. And so this ultimate high-risk group was created under the support of the federal government called Medicare. And it's available to all of US citizens who've paid into payroll once you turn 65. The other group that gets Medicare are if you've been working and you become disabled, after 2 years you qualify for Medicare. I bring that to your attention because if you think about all you hear in the press about how outrageously expensive Medicare is and we can't afford this, the reason is that in 1965 they took all the high-risk people and put them into their own group. And in 1965 the average life expectancy was about 70. Today it's 82 years for a woman in Colorado. And so we have this high-risk group that the government is funding through a Medicare tax. The second government program created was Medicaid. And Medicaid was put out there for people who could not afford to buy insurance. It was an income-based program. And Medicaid is different from Medicare in that it is a state and federal partnership. And each state decides on its own how much, if any, Medicaid it will offer. There's a minimum that you need to offer for the federal government to partner in this project with you. And then it can go up to a pretty significant maximum. And so Medicaid, for the most part in the past, has been paid 50% by the state. And every dollar we pitch in is matched 50% by the federal government. And the income requirements for Medicaid vary state by state. But what I want to tell you if you live in Colorado is that before 2014 and the Affordable Care Act, it didn't matter how poor you were. If you did not have children or you were not disabled, you did not qualify for Medicaid in the state of Colorado. So all those people who are homeless and not working, living in the malls and on the streets, if they were not medically disabled, if they did not have children, they did not have access to health care. They were uninsured. And so that was the first major intervention by government in health care in 1965. Unfortunately, you guys kept creating new, exciting advances that not only kept people alive, but cost lots of money. And so insurance was having a harder and harder time collecting enough money to cover everybody's expenses. And so they started excluding people. The first group that was excluded were people with pre-existing conditions. So if you ever got cancer, it was hard for you to find somebody to offer you insurance once they knew you had cancer because your chance of having a recurrence or needing treatment was increased. But it got to the point where literally insurers would pay, let's say that we found out you had a tumor, and insurance would pay somebody to go through all your medical records to see if there was anything you didn't report in your application for insurance. And if there was, they would cancel your insurance after you've now been diagnosed with a treatable disease, give you back all your premiums, and make you uninsured again. That was called rescission. And then it also got to the point where in Colorado there was a news story on the front page where Rocky Mountain Health Plans on the western slope had refused to insure a baby because he was fat. And so I like to say that we got to the point where living beyond the age of 50 was a pre-existing condition. And it became really hard to find people who were willing to insure you if you were over the age of 50, particularly if you were Latino like me, which increases my risk for diabetes, overweight, whatever it might be. And so, but even with doing that and excluding all those people, because of you darn scientists and advances in medicine, the cost of health insurance continued to increase. And it got to the point where for a single person in 2012 to buy a plan, it would cost approximately $5,615 a year. For a family, it would cost about $15,745 a year. Now, in 2012, the average household income was $51,759. And so you had the situation where unless you got insurance through your employer, it was really hard for you to afford to buy insurance. Now, I always like to put this point in, and this is just because as we talk about this, I want you to remember this. So the United States is the only industrialized country in the world that does not guarantee access to basic health care for its population. The only one in the world. Despite that, we spend more on health care than any of the other developed countries do. And if you look at that chart, the darker blue line on the bottom is what the government pays directly for health care. The reason there's a red line in the United States is that's that extra $150 billion that we give in tax deductions for corporations that buy health care. So you can see that other than Switzerland, our government alone spends more on health care than any other developed country in the world. And this is one of the first things I learned about healthcare reform in 2007 that really sort of ignited my passion around trying to change this, because it just didn't seem right to me that we spent so much money and yet we didn't guarantee people access to health care. But anyway, we were at the premiums being 30% of income, so that by the time President Obama was in office, we had about 16% of our country uninsured. And of those people who had insurance, about 12.5% had Medicaid, another 10% had Medicare, and so we only had about 60% of our population that was using the private insurance system to pay for their health care costs. And if you were to ask people, why don't you have health insurance, the answers were either no one will give it to me because of pre-existing conditions, or frankly, I can't afford it. And so it was based on that that the Affordable Care Act came into being. And as you know, as you've heard, it's been very controversial. There have been 61 votes in Congress to repeal the Affordable Care Act. There has been one vote that's made it all the way to the president's desk. He vetoed it this past year in 2015. And if you talk with people about it, what you'll find is that they really like all the provisions of the Affordable Care Act. They just don't want to have to pay for it, basically. So some of the provisions were that you could no longer look through your medical records and cancel your insurance policy and give you your money back. If you were a family, your children could be on your plan until you were 26. And if you were actually health insurance, in the past, you could buy a policy that literally had a $50,000 a year maximum that could be paid out. And knowing some of the drugs you are inventing, you know that that could treat maybe 1 month's worth of one disease in some cases. And then other insurance plans had lifetime maximums. And once you reached that lifetime maximum, you no longer had insurance. And so all of those were done away with the Affordable Care Act. But here is the central bargain that people have not bought into in the United States. And this is that if you want to make health care affordable, then everyone needs to buy it, even when they're healthy. Because if people only buy health insurance when they're sick, nobody can afford that, because everybody pitching in is going to have high costs. So you need everybody to pitch in. So the deal that was made with the private health insurers was, look, insurers, you can no longer discriminate against people based on pre-existing conditions, and in exchange for that, everybody has to buy health insurance. The name for that is the individual mandate. As you know, that was taken to the Supreme Court to challenge its constitutionality, and that mandate was upheld. And so that was the central bargain of the Affordable Care Act. Now, the other thing that was in the Affordable Care Act that got taken to the Supreme Court was Medicaid expansion. If you recall, I mentioned that in Colorado, if you lived in poverty, you did not have Medicaid. The federal government said, okay, states, we will pay 100% of the cost for people who live in poverty to have access to Medicaid for 3 years, and then we will decrease how much we contribute to the point where we'll be paying 90% of the cost for the new populations you're covering in Medicaid, and you'll pay 10% of the cost starting in 2020. So you go from a 50-50 deal to a 90-10 deal. And the ideologic resistance to that is so great that only 31 of our 50 states have chosen to expand Medicaid. There are still 19 states where people in poverty do not have access to health care, even with the federal government paying the full cost for 3 years. So that was taken to the Supreme Court because initially it was going to be mandated that every state had to do this, and the Supreme Court said, no, you can't force a state to do this since they're going to have to pitch in 10%, and so it became something that a state could elect to do or not. And thankfully, in 2013, we passed a bill in Colorado to allow Medicaid expansion in our state, and the impact of that has been dramatic. And in fact, the number of uninsured in the state of Colorado has gone from 14.3% to 6.7%. That is a decrease of about 400,000 people now. 400,000 more people have insurance in the state of Colorado. What I have to tell you, though, is that during that time, we added 450,000 people to Medicaid. So the success of the Affordable Care Act in the state of Colorado has primarily been one of Medicaid expansion. In fact, we now have 1.2 million people of our 5 million people in the state of Colorado are covered by Medicaid. We're left with about 350,000 people without insurance. About 90,000 of those are children. About 70,000 of those are people who are not documented. This is just for your reference what the federal poverty levels are. So if you are an individual, and many people are surprised to see that, in fact, they qualify for Medicaid. If you're an individual and your annual income is under $16,000 a year, you qualify for Medicaid in the state of Colorado. And if you're a family of 4 and your income is under $32,900, you qualify for Medicaid in the state of Colorado. The reason that 400% thing is there is that what the federal government said was, look, everybody has to buy insurance, but we know you can't all afford it. So if your income is below 400% of the federal poverty level and you go to an exchange, and I'll tell you about that in a moment, we will give you advanced premium tax credits to help you buy your insurance so that it's not costing you more than 9.5% of your income to purchase private health insurance. And so that's why the 400% is up there. If you make under 400% of the federal poverty level and you purchase your insurance through a health exchange, you get a contribution toward your premium so that you don't have to pay the full price. So Colorado, in addition to expanding Medicaid, set up its own state-based health exchange, and we have about 168,000 people who have purchased insurance through the exchange. About 125,000 of those have received subsidies or advanced premium tax credits. In 2015, the value of that was $215 million. It was given to people in the state of Colorado to help them purchase private insurance. If you don't purchase insurance, you are subject to a tax penalty. Unfortunately, the price of that penalty, I shouldn't say unfortunately, I mean, it's not very high. So, for example, the highest your penalty can be is $695 a year for not having bought insurance as an adult. The maximum for a family is $2,085 for not buying insurance. I have a 26-year-old niece who cares for my daughter who's disabled. She pays $157 a month for her catastrophic plan. So she pays about $2,000 a year for an insurance that actually doesn't kick in until she's spent $4,350 out of pocket. And so if you're very healthy, you're like, okay, do I pay the $150 a month for something that I won't be able to use until I've spent $4,000, or do I just pay the penalty? And so this has been one of the issues with the Affordable Care Act, is that in spite of the idea of saying, okay, you offer insurance to everybody, everybody will buy insurance, there have been people who've chosen not to buy insurance because they're healthy and the penalty is less than what they have to pay to buy insurance. So why aren't I happy with what we've done with healthcare in Colorado? There's another small number here you might not have noticed, and this is something called underinsurance. And what underinsurance means is that after having bought your health insurance, you still have to spend 10% of your disposable income in order to access health care. So my niece falls into the category of underinsured. And as you can see, over time, that number is increasing to now we have 16.4% of our population in the state of Colorado that is underinsured. In spite of that, we have continued rising health care costs. We have a complicated, opaque payment system. Our system is much more profit-driven, not outcome-driven, and there really is no incentive to care for our most complex, costly patients in our state. So let me go over why these are important. This is what my husband calls my nerd slide, but I think you're nerds enough here that you can understand it. So this is what I want you to see in this slide. I want you to see the far right corner, where it says that 50% of a population only accounts for 3% of healthcare spending. So the United States is up to spending $3.1 trillion a year on healthcare. 50% of us only spend 3% of that money. But if you look to the left, the third column in particular, or fourth column, the top 20% of our population accounts for 82% of our healthcare spending. And as you would imagine, that represents people who are elderly, people who are disabled, and people who have chronic medical conditions. And so when I hear Larry talking about, identifying women in advance who might get ovarian cancer and offering them perhaps a cure, that would save our spending tremendously if we could cure people as opposed to doing the expensive interventions that we do right now. But the reason this is important for you to look at is that when you sit there and say, oh my God, why do I have to spend $16,000 a year for health insurance? I'm really healthy. You're exactly right. This is a product you buy hoping you'll never have to use it. And you're paying your $16,000 so that population on the left side that does need health insurance can get the care that they need. And so this is sort of the grand bargain we're in. We all pitch in. Paradoxically, we hope we never have to use it. And the money is there for those people who do need to use it to pay for their health care. Remember I mentioned how the penalty is not very high under the Affordable Care Act? Well, because of that, the cost of insurance is continuing to increase every year. And that's because, as I said, just people who really need insurance are buying it. In fact, one of the paradoxes is that the insurers have found that offering health insurance to people who need tax credits to help them buy it is expensive. And next year, United Healthcare will no longer offer health insurance on our exchange because they can't make a profit doing that. And so the cost of insurance continues to increase. The way that insurance companies try to control their costs is to have the individual put more skin in the game, which means you have to pay more of the cost on your own. What's interesting is there are ways to design this so that disproportionately more healthy people buy your insurance plan. So one of the games played in this is something called narrow networks. A narrow network means that you agree to see only these doctors. Now, if you're 100% healthy, you could care less what doctors are in your network. But if you have MS, you want to be sure that you could see that doctor who specializes in MS, and they're not likely to be in that narrow network. And so by designing narrow network plans that are less expensive, health insurers disproportionately get healthier people. The other way in which unhealthy people are discriminated against is through the drug payment policies in terms of how many tiers of drugs and what the out-of-pocket cost is for those drugs. So it's entirely possible to have an insurance plan where you have to pay the first 3 months of your drug 100% out of your pocket. And so people literally with rheumatoid arthritis or multiple sclerosis are choosing not to buy those drugs because they can't afford to pay it up front. And so that's part of what underinsurance looks like. The complicated, opaque payment system. One of the strange things about healthcare is that if you call and ask how much will this cost me, nobody can tell you for the most part, particularly in a hospital. So this is something available here in Colorado. It's through the Center for Improving Value in Healthcare. It's called the All Payer Claims Database. And this is the price that these 20 whatever hospitals pay for a total knee replacement. And you can see that hospitals are reimbursed as little as $20,000 and as much as $50,000. Now, if I told you that the hospital got paid $50,000 because you had the best outcome, no complications, you could run a marathon afterwards, you might think that's a good value statement. Unfortunately, the way in which these prices are determined is completely arbitrary. So you might have read in the newspaper about how our mountain regions have outrageously high costs for health insurance. The reason is that there's one hospital in Summit County. So they could decide what price they want to charge for a knee replacement, because if you want to offer insurance in Summit County, you have to have a contract with them. And so this is one of the distortions in our healthcare system that leads to waste and a maldistribution of profit. What this does as well is lead to headache for doctors. And every time I think about whether I want to go back to practicing medicine, I look at this slide. Because it was great working at Denver Health, but starting in about 2007, some of these insurance impacts started to hit us at Denver Health. And I literally, if I wanted to give you a medicine for an ulcer, I had to know what kind of insurance you had, because depending on your insurance, different medicines were covered. and the co-payments for you were different. And if I thought you really needed a very specialized medicine, I had to be willing to fill out a 2-page form for you and wait for that result to come in. And so to try and control costs, we've set up this complex system where 3 doctors working in an office need a staff of 4 to help them do their billing and scheduling for their patients. The other thing that we did in the United States is when we got drug coverage under Medicare Part D under President Bush, we specifically put into our law that Medicare would never negotiate for drug prices for patients. And so this is the difference. The red line is what we pay in the US. Blue, green, and yellow are other countries, what they pay for the exact same high-tech drug that we pay here in the United States because we are not allowed to negotiate drug prices. The state of Maine tried to pass a law saying that you could go to Canada and get your drugs and your insurance could pay for it, and pharma has sued them to not implement that law. The profit margin in pharma is 10 to 20% globally, 20% more in the US. The system, unfortunately, you put a bunch of money, $3.1 trillion somewhere, and people figure out how they can get a piece of that money, and they're very ingenious about it. And so one of the ways this is happening now in Colorado is the advent of something called freestanding emergency rooms. I don't know if you ever trip and sprain your ankle, make sure it says urgent care and not emergency room, because that makes a big difference. If you're in an emergency room, you can charge a facility charge. And this is the difference in average billing between an urgent care center and an emergency room for the exact same treatment. 3 years ago in the legislature, I tried to run a bill that said that if you are not part of a hospital, you can't charge a facility fee. I was crushed. I was seen as not understanding how the free market works. And what was funny was at the end of that session, an investor from New York called to ask me if I'd be running that bill again because he was advising his clients on where to invest their money. Anyway, so the other way in which we really distort how we spend money in our healthcare system now is through our hospitals. You might have noticed that your hospitals are building chains up and down the Front Range. I could tell you nobody's building in Lyman and nobody is building in Montrose because there's not money in Lyman and Montrose because the rate of uninsured and the rate of people on Medicaid is higher there. And so this is the profit margin for our Health One system and the operating margin for University Hospital. This is public data available in 2014 from Alan Baumgartner. What that represents, those 2 entities there, is $1 billion in healthcare in Colorado that goes to not providing healthcare, but to being part of the operating margins. And really to building more hospitals so they can negotiate higher prices with the insurance company. We're also seeing mergers in our insurance companies. Anthem and Cigna are merging in Colorado, and Aetna and Humana are merging in Colorado, which again gives them better bargaining power. And unfortunately, none of this is based on quality and outcomes. It's all based on bargaining power. Now, this as a primary care provider is one of those issues that's really important to me. We provide no incentive to care for our most complex, costly patients. So remember that 80% of our healthcare dollar is spent on that 20% of patients who are more likely to be poor, more likely to be elderly. Well, when Medicare patients go to see a doctor, the doctor gets reimbursed about 30% of what they get from a private insurer. If we were to put Medicaid on this chart, it would be even lower. And so we have the system where the people who most need health care are discriminated against in our healthcare system because they don't reimburse enough. And so, so that is one of the other things we need to fix. Now, the paradox is when they can't get the health care they need and they end up in the hospital and the hospital gets reimbursed poorly because they have Medicare or Medicaid, the hospital transfers those charges to their private insured patients. So we all pay for it. So we never get out of paying the bill. It's just a matter of doing it backwards. So what Amendment 69 wants to do is just completely check this and say, look, we pay for health care for everybody anyway. Why don't we just do this in an upfront, transparent manner where we can decrease administrative costs, we can do bulk negotiation, and we can focus on taking care of the high-cost patients. And so that's what Amendment 69 or ColoradoCare is. Now this is the part that you'll hear about, and you won't hear more than this from the opposition, because it's the easy part to hit us on, which is that in order to be sure that everybody is contributing, the best way to do that is just to collect it up front like Medicare does as a payroll premium. And this means then that individuals will pay 3.33% of their income instead of the current health care premiums they pay, deductibles, and other out-of-pocket expenses. So this means that everybody is contributing, there's no escaping paying, and everybody then benefits. The big difference here is instead of an absolute number of $16,000 a year, you pay 3.33% of what you earn. And so interestingly, for 80% of Coloradans, that's less than what they would pay right now for a comparable policy. And then employers will have to pay 6.67% of payroll to provide a platinum level benefit for all their employees, and it will also cover the medical portion of workman's comp. On average, if an employer does provide health insurance for their employee, they're spending 10 to 12% of payroll. If an employer does not provide health insurance for their employee, it's significantly less. So for those employers, it is an increase in cost. You might have heard of some of the gaming going on under the Affordable Care Act, where employers with employees who work more than 30 hours a week are required to buy health insurance. And so a lot of employers are only offering 28-hour-a-week jobs to avoid that. Well, one of the things that ColoradoCare does is it says, I don't care how many hours people work for you, you contribute for all the payroll that you're paying. And so in this new day and age where young people might work for 2 or 3 different people, every one of their employers is contributing. Now this is my paycheck. I want you to know that I make $30,000 a year as a senator. And the biggest advantage I get, though, is this incredible HMO insurance plan for which I pay $402 a month, and the state pays $1,230 a month. So monthly, I get paid $2,500, and Kaiser gets paid $1,600 for my health insurance. Under ColoradoCare, I would pay $107.83, and the state would pay $237.33 because the contribution would be based on my income, not on an absolute number. And in fact, when the state has run the numbers on what ColoradoCare does for state spending, it actually saves them millions of dollars that can be invested in other areas in the state of Colorado. Now, just like other income taxes, if you are self-employed, you have to pay the whole amount because you are the employer, you are the employee. This amount is deductible from your federal taxes, so the effective tax rate is lower. And there actually is a cap on this. If you make, as a couple, over $450,000 a year, only the first $450,000 is subject to the premium. And as an individual, only the first $350,000 is subject to the premium. If you're retired, you are still contributing to the system. There are more articles coming out now about how people on Medicare are starting to go bankrupt because they can't afford their co-payments and their medications. So this would provide universal coverage for people on Medicare as well. They get to exempt their first $33,000 or $60,000 of income from contributing to the ColoradoCare Trust Plan. And in exchange for that, they get their Advantage Plus plan or 100% coverage. And so on the open market, it would be about $3,080 for a couple making $100,000 a year versus about a $4,800 plan right now. The benefits we had priced are essentially Medicaid benefits, so a very rich level of benefits with very low co-payments and everything that's required under the Affordable Care Act. And in fact, the pricing includes no deductibles, no co-insurance, no co-payments on preventive care, modest co-payments for other care that can be waived if it's going to keep you from being healthy. And so how do we pay for this? How can we charge so much less and make more? Well, we know that we waste about 30% of our healthcare dollar, and ColoradoCare will look at recouping some of that wastage and using it instead of for other things to actually pay for healthcare. So we know we'll get the $1 billion from the hospitals for a start. But anyway, this is sort of a schematic of how you figure out right now how you get insurance and who's going to help you pay for it. This is what it would look like under ColoradoCare. Basically, you live in our state, you pay taxes, you're covered. This is a schematic of, on average, how much the US pays for pharmaceuticals. This is similar for DME, hospitalization, other things versus other countries. We'd be able to significantly lower that, and with those savings, provide coverage for everybody at a much richer benefit. And most importantly, we could do what the Netherlands has done, which is to find a way to prioritize the care of the complex, high-cost patient. In the Netherlands, they switched to providing care management teams around those really costly patients. They went from needing 150 hospitals to needing 70, and we're hoping to go down to 50 in the next few years, just from redirecting how they took care of patients and aligning the incentives to the health of the population and not the profit margin of the place providing care. Now, this is a lot of money that's collected, and it will go into a healthcare trust fund that will be governed by a 21-member elected board of directors. The state has about 7 geographic medical neighborhoods. Each of these 7 medical neighborhoods would elect 3 people to the central board of directors to represent their interests and to make the decisions on the plan. And the central board of directors, in addition to determining how things are paid for, would have to make sure that we kept enough hospitals open in the right places across the state. There are rural areas that really need hospitals. Under the current market forces, they can't afford them. But under ColoradoCare, we could pay for a hospital to be there. And also to be sure that we have emergency transportation and money left in case unexpected illnesses came up in certain geographic regions so they could be covered. So in closing, this would be a Colorado resident-owned system. It would cover every Colorado resident. It would ensure comprehensive, high-quality, Platinum Plus, accessible and affordable lifetime health care. We would collect premiums from everyone in Colorado based on income, and it would cost significantly less than our current system. And in fact, the economic analysis done by Dr. Friedman out of UMass Amherst indicates that it would significantly bend the cost curve in spending in the state of Colorado so that in the future, we would have much more money left to invest in other areas of economic development and not just in healthcare. And so I hope that you will all consider who live and are registered to vote in Colorado, voting yes on Amendment 69 in November. And I thank you for your attention.
So we have time for a few questions. I see a hand up right there.
I guess the obvious question would be, why wouldn't anyone want to vote for this? And I guess one thing I wanted to bring up is, how will this affect people's selection of their healthcare providers? That's a big issue for a lot of people.
Right. So I could tell you some of why people would want to vote again for this by telling you who is funding the opposition. In our first quarter's filings, we collected $160,000 from 1,500 people. The opposition got $1 million from about 10 groups, the first of which was Anthem Blue Cross Blue Shield, which paid $500,000. The second one, which really sort of surprised me, was Sisters of Charity of Leavenworth, which is a faith-based nonprofit hospital system. And they contributed $100,000 to defeat our amendment. And so certainly the people who are making a lot of money off our current healthcare system don't want this to pass because we would have more reasonable profit margins. You know, hospital could stay up to date with a 5 to 10% profit margin. They don't really need a 33% profit margin. And then we have a lot of ideologues in our country who really believe that I am not my brother's keeper. And if you get sick and you don't have insurance, that's your problem. Now, the problem with that belief is that if you get sick and you don't have insurance and you come into my emergency room, I'm going to treat you. And the fact that you don't have insurance just means that the person who does is going to pay more. And so unless we find a way in our country to label people and we scan them and say, I'm going to let this one sit here and die, it doesn't make sense not to pay for everybody to have health care. And as Larry was talking about with his vision for the future, you know, how much cheaper is it to pay to treat somebody's high blood pressure than to care for them 24/7 in a nursing home because they've had a disabling stroke? I mean, it really undermines our own advancement as a society. But those are the people who are opposed to this. And then really, a lot of people think they have good health insurance now, and that's because they're healthy. You really don't know how good your health insurance is until you get sick. And so you may not pay very much right now, and you may make $300,000 and say, oh my God, this is going to cost me so much more. But that day when you get sick and you need to access the doctor that you want, it will be there for you. Yes, sir.
Sorry. First of all, thank you very much. That was a wonderful, inspiring presentation. I do have a couple of questions. Well, quick observation. The transformation of health practice based on a plan like this will be phenomenal because the overhead cost, as you well know from experience and otherwise, in the physician practice around billing and all
Well,
of
and the
that is,
burnout that comes with
right.
it. We're seeing
So
unprecedented
it would
levels
be
of
quite
burnout.
remarkable. The big issue at the end of the day, however, whether one has a single payer system or whatever, is being able to, in a sense, control costs,
Right.
but not through demand management. Demand management, as you know,
Correct.
was really a function of short-term insurance, where nobody really had the risk for a lifetime or for a long period of time. How do you see this going forward in terms of controlling cost? And actually, I think controlling cost is not the right way to put it. Improving outcomes,
Right.
so there isn't cost.
Right.
The other question I have has to do with the commission or the group that's going to oversee this. Historically, one of the great problems in the NHS in England, which I've spent many, many years both living and working with, has been the politicization of those who oversee the healthcare system.
Right.
So I know Tom Daschle, who didn't become HHS secretary, his goal, if he had been under Obama, was actually to depoliticize oversight of Medicare by taking it away from day-to-day meddling by Congress.
Right.
And so the question there is, how do you depoliticize that commission as well?
So the reason I show you that nerd slide about how 20% of patients account for 82% of the spending is that one of the ways in which we're engaged in self-defeating behavior in the United States is that we don't align incentives. And so that example about the Netherlands going from 150 to 70 hospitals, you think that hospitals are about 40% of our total cost. If we can really align incentives and keep people healthy and out of the hospital, that provides the income for the future growths in healthcare. And the estimate that was done, and if you go to ColoradoCare, yes, or ColoradoCare.org, I think is the website, you can see the full economic analysis. But the estimate is that we actually are collecting about $4 billion more than we need. So we have built in a slush fund, and the calculations are done on current patterns of healthcare spending, not looking at redesigning how we spend healthcare. One of the other interesting things about having an insurance-based system in the United States is that an insurer anticipates having a customer for about 3 years. And so when they do their risk-benefit analysis, they want to know they're going to get an ROI in 3 years. The trust fund for ColoradoCare is birth to cradle, cradle to grave. And so the investment structure is very different. And so that the tests that Larry's group are going to develop to an insurer might not look worth it to them, because in 3 years that woman may never get ovarian cancer. But to someone who's covering you from cradle to grave, your ROI is great there. The seats are elected, and it has a lot to do with mistrust even in appointment. And there are term limits. There is the ability to vote someone off the island if they're not contributing to advancement of the system. And there are going to be strict campaign laws around that. And so I think it's the best we can hope in a democracy.
So let me take just one more question, and then we'll go on to the next speaker, and Senator Aguilar will be around to answer questions during the break. So I see someone up there.
No, I think he gave someone a microphone there.
I wish you good luck with this ballot initiative. You've picked a year with a lot of noise with the presidential, especially in this state because it's a battleground state. Have you considered that, given that you're being out fundraised?
That I'm pardon?
You're being out fundraised based on the numbers
Yeah.
you just shared with us.
So we picked a presidential year on purpose because you tend to get higher turnout and more turnout from the disenfranchised. Colorado is one of those states where, at least in the Democratic Party, went 70-20 Bernie, 70-30 Bernie, Hillary, or 65-35 Bernie, Hillary. So we have a lot of energy in our state that's sort of anti-corporate. The big guys aren't working in our favor, so we're hoping that will help us. And one of the good things about being a battleground state is that I would guess that a lot of the advertising time has already been bought for November. So we're hoping that Their $1 million isn't going to buy them as much as they hope.
Take that one question that I acknowledged up there, and then we'll take the break. I think there was someone right in the middle here.
Hi, I'm a physician and I practiced endocrinology for 30 years. Now, I found, and I took care of a lot of diabetics, that lots of people don't take care of themselves or learn to take care of themselves. So there are 3 issues that I have with this plan. It's great overall, but the first issue is a societal issue.
Right.
Diabetes comes from obesity. You can't go to a restaurant and not get obese. How are you going to deal with that? Second is, how do you change that culture? How do you change patients' responsibility for their care? Somebody won't measure their blood sugar every day or every whatever time. Somebody won't measure their blood pressure or learn how to adjust their blood pressure medicine themselves. How do you deal with that in this plan? And the third is the state can't adjudicate the claims. They outsource it to the insurance company, and the insurance company prices all of this. How do you control that pricing?
So we didn't get to talk into details very much. Actually, the role of private insurance is very limited. It will be sort of like public-private school. Most people will be covered by the system, which will have an ombudsman both for patients and for providers for complaints to be discussed. I do think that every time I give a lecture, the question of skin in the game comes up for the patient. I always remind people that the ultimate skin in the game is that you lose your life and you lose your ability to function as an independent human being. But there are models that have been used. I know I've heard in Germany, for example, that if you don't do your regular dental maintenance, that when you need corrective care, it's not funded at the same level. So those kinds of options are available to deal with recalcitrant people. And finally, just out of interest, at Denver Health, we had a grant to look at the high-cost patient. And interestingly, the number one identifier of a high-cost patient was somebody who had undiagnosed or undertreated mental health and substance abuse issues. So as you notice, mental health and substance abuse is part of this system. I think when we cut mental health treatment out of our healthcare system, we did ourselves a disservice because those folks manifest as physical manifestations of mental disease. And so I think, there will be a small percentage who will abuse the system. You just deal with that and you find other ways to incentivize them. But I think for the bulk of the population, it'll be much more beneficial. Thank you.
Thank you very much. So our